Good afternoon. Hope all of y'all are doing well today. My name is Dr. Connie Arnold. I'm a professor of medicine, and today I'm going to give a talk about risk communication. It is a timely topic. It's something that y'all are faced with every day, whether you're doing procedures. It's something that's huge in clinical trials. And the issue is, what do patients really understand when we talk about risk communication? So risk communication creeps into our lives. It's in public service announcements that educate us about what a stroke looks like. Our cars beep at us, television ad, magazines show how our brains look. Do any of y'all remember what does your brain look like on drugs, fried egg? Y'all may be too young for that one. I put that one in there because that's what ads used to look like, and they were physicians selling cigarettes. Some of the more ones that have a bigger impact, at least that I've seen on television lately, are the former smokers. There's the guy who has he takes off his shirt, he's had open heart surgery. And so they're very impactful. So we're targeted in all different kinds of ways. So I always like to show this. Over 40% of passengers, when you talk about risk communication, express some fear or anxiety when they have a fear of flying. And that's a perception that the plane is going to crash. In reality, only a staggering 96% of people who are on planes that crash actually survive. Most people don't know that. And we all know that the odds of dying in a car accident are much greater. It doesn't necessarily help alleviate your fear if you're afraid of flying. But do we know anything about what'll lessen your risk if you're on a plane? Sure we do. We do research on everything. Since I gave a talk on risk communication about 6 or 7 years ago, and I now count the exit, how many seats I am from the exit row, because it increases your rate of survival, is getting off the plane. So that was just a way to show you one of the ways when we talk about risk communication, and also what people's perception is. So today what I want to talk to you about is to discuss the problems we have with low health numeracy, give you some examples of how numerical information is presented, and how it's presented can affect patient decision making, and discuss problems with and how to improve risk communication. So every day patients are confronted with difficult types of decisions. What type of treatment should they receive? Should they go on a clinical trial? What are the risks of their lifestyle choices? What are the risks of the medications they take? I like this cartoon. I warned you the fertility drugs might have side effects. And so the ultimate purpose of risk communication is to enable people at risk to make informed decisions based on to protect themselves and their loved ones. So we know that literacy is a problem. Y'all probably heard the lectures on low literacy. We know that 1 in 5 adults have low literacy. It's greater with the elderly, minorities. But literacy is more than reading. This is something that my colleague, Dr. Terry Davis, and I always emphasize. Literacy is not just reading. It's listening, it's reading, it's writing, it's speaking in English, it's communicating, computing math skills, and it's solving problems. So people with low literacy, we know, have poorer physical and mental health. They have riskier health behaviors. They use less preventive services. They have more delayed diagnosis. They have poor self-management. They have more hospitalizations. So what is health numeracy? Numeracy, defined by the Journal of Asthma, was an aspect of health literacy that includes the quantitative skills necessary to understand and act on numerical directions given by a healthcare provider. Another way to say it is health numeracy is the ability to access, interpret, and use quantitative information that you're given. What does it look like when our patients have to use health numeracy? Well, they have to look at labels if they're diabetics, and they have to figure out things. They have to be able to take their medications and understand how to do that. They have to understand the severity of their risk. If somebody shows them a graph or a picture, they have to understand what it means of where their blood pressure may be and are they at risk. Just like low health literacy, low numeracy is tied to shorter life expectancy, lower health outcomes overall. They have a higher incidence of ER visits. If you don't understand, if you can't figure out how to take your medications correctly, you may be ending up in the ER if you're dosing it incorrectly. If you don't know what the numbers about your blood sugar or your blood pressure mean, that means you're going to end up in the ER more often. You're going to have higher hospitalizations. So why does health numeracy matter? Just like health literacy, there is a direct relationship to health disparities and health numeracy. And today there is a greater emphasis on shared decision making. That's what we talk about a lot in medicine, that we want patients to participate in their own health care. And in order to do that, they have to understand what we're talking to them about. And there's more quantitative information than ever before. I mean, if you ever listen to the news or whatever, people throw numbers at you all the time. So what is the scope of the problem? So over half of U.S. adults only have basic or below basic number skills. Math anxiety. Y'all may be too young for this, but when I took math in school, I was a math major halfway through my undergraduate degree. Math anxiety, an intense lifelong fear of two trains approaching each other at speeds of 60 and 80 miles per hour. I used to always do reading problems like that. Math anxiety is something that patients actually have. And so you add that to they're sick, they're in pain, they're in stress, they have a child with them that's sick, and you start throwing numbers at them, and all of a sudden, they're completely lost. The elderly, the less educated and non-English speaking, and those at low socioeconomic status are at greater risk. Numeracy skills are far worse than literacy skills. Many patients with adequate literacy skills actually have inadequate health numeracy skills. Approximately half of U.S. adults are unable to calculate a tip. You know, now online, like if you order something online or lots of restaurants, they calculate the tip for you. They have the percentages out there. And 20% of college-educated adults don't know what is a higher risk, 1%, 5%, or 10%. So problems for people with low numeracy skills include navigating the health system. They have problems scheduling appointments and accessing care. They have problems understanding their health plan requirements. They have problems completing health insurance forms. They have problems interpreting and following treatment plans. And more importantly, they have difficulty weighing the risk and benefits of medical interventions. So what about math skills when you go to give Amoxyl? This particular prescription said, give 4 cc 3 times a day for 10 days. So is that, for some patients, is that 3 times means 7, 7:15, 7:30? What's the context of it? Do I divide 3 by 24 hours in a day? Am I getting my child up in the middle of the day? Do you understand measurement? I can guarantee you that a lot of our patients, this is how they measure that out. There is not a syringe or a cup with it that's already measured. And the idea of a teaspoon to all of them, those are teaspoons of our patients. So that's the same measurement for everybody. And where do you put the Amoxyl? Is it in your ear? You know, we assume people, when it says orally, that you would know that you took it by mouth. And there are a lot of our patients who don't understand that means orally means by mouth. So can patients understand research findings? You know, one of the requirements of NIH, ACS, when you do a grant, is you have to share your research findings with the people that were involved in your study. But do they understand what we're telling them that we found? So a team of researchers found that the risk of X cancer was 1 in 2, this is a study that was done, 1 in 250 in 2000, and they predicted that it would rise to 1 in 150 by year 2015. So then they did a focus group. What did those numbers mean to them? People were confused because many people thought the number of cases decreased because 150 is less than 250. So they thought, okay, it's going down. They also wanted the risk numbers explained. 1 in 250, without any context of that, is that a lot? Is that not very much? Our patients don't get a grasp of that. So there was another study we now have digital thermometers, and you're told that your baby's doctor said to call if the baby has a temperature of 100.4. And they had to look at the thermometer, and it said 100.2. Should you call the doctor? No. 69% got it right. That means 40% of patients didn't understand the digital thermometer. So how do patients learn? The first sight of, like I said before, of a number or graph can bring on anxiety in patients. But it also can distract them from what you're trying to tell them, because they're still back there trying to figure out what the first part of what you told them was. And so knowing when not to use numbers is just as important as knowing how to use them. The idea is to focus on the outcomes and the actions. So there is a theory, and it's called fuzzy trace theory. And this is how patients learn math. So it's divided into two ways. Verbatim thinking, which is people who want the precise details and facts. They want they recall and numbers and details, and it's deliberate and precise and it's quantitative. And then there's the gist-based thinking. It's vague, it's the bottom line, just cut to the chase. It's subjective. It also can be influenced by their emotion, by their culture, by their education, what they've experienced. And the majority of people rely on gist-based thinking to make the most important decisions. Here's the fuzzy part of the theory. Since we rarely remember every detail of a conversation, we kind of get the gist of it and our brain tries to construct that through something around it. When we're given a slew of information, what happens is the brain automatically strives to extract a simple one-note meaning from that, the gist of it. Patients tend to fully accept or fully reject a notion based on their first impression. And so if we aren't careful, what happens is patients may arrive at different bottom line messages than what we're trying to get at. So the idea is to focus on bridging information and action through gist-based messaging first, and then add numbers if it helps reinforce it. So here's an example. So Mr. Fisher, your systolic blood pressure is 150 and your diastolic is 95. Or you could say, people say your blood pressure is 150 over 95. That's probably more usual what you say. You'll cut your risk of heart disease by 50% if you can quit smoking. We could also put you on 25 milligrams of beta blocker once a day, and what do you think about that? An easier way to say that is your blood pressure is high. And if you want to visualize, that's fine. If you quit smoking, you can cut your risk of heart disease in half, and there's also medications that can help. You're limiting what the first line of information you give them is. And then you go into more details. You want to compartmentalize it so that they get the general idea. What is the main message of that? Your blood pressure's high and we need to do something about it. You're smoking and it would be nice if you stopped. Then you go into more details. Patients who want to know what their exact numbers are going to ask you. Usually patients just want to know, you rattle off numbers and it really doesn't necessarily mean anything to them. So when we look at using numbers with patients, there's a hierarchy of the way that numbers that patients recognize that some are easier and some are difficult. And it starts with the basic level of reading numbers and counting and telling time and goes all the way up to statistical, which are the most hard for people to comprehend. And that means interpreting risk statements, reading complex graphs, comparing numbers on different scales. So order is always important. Start with the most important information first. Put figures in logical order, such as by date or alphabetically. Consider using descending order instead of ascending order. So when big equals bad, start with that as the most important value. Less is always more. That's true when you're talking with patients about health literacy or whether you're talking about numeracy. less is always more. One idea at a time, which is just what I described, and underscore the gist of each piece. It's always better to round off and use similar denominations. 78.6.4%, excuse me. It's better to say 79 or 80%. And rather than mixing your denominators when you're talking about 1 in 10 versus 1 in 5, it's better to say 1 in 10 and 2 in 10, and keeping them similar so the patients don't get confused. Do the math for patients. It's very helpful to mark medicine cups and syringes or use pill cards. Tables. If you want to know one of my pet peeves, I sit on the IRB and I have to review consent forms. And researchers, we love tables. We love to put everything in tables. Tables are a mathematical concept. And you have to be able, one of the things I always tell people when I'm trying to simplify when they put on their consent form, a table. And this is actually a table from one of the consent forms I reviewed that I just started laughing when I looked at it because I spent 30 minutes trying to figure this table out. And the problem is we take for granted about how to read a table, to look horizontally, go vertically, how to read the columns. A lot of our patients don't understand it. This table had subnotes, so I had to look down on it and find out information. It used things instead of just saying you're in group A or B. It used screen A and screen B, which patients don't understand. But as you can tell, they wanted the patient to, whichever group they were in, to figure out which of these things they were going to have to do. So tables are very difficult for patients who have low numeracy skills. Narrative support is always important. And one of the things that we've learned through research about talking about numbers is if you can put it in a story, if you can put it in some kind of context, oftentimes patients get it. And one good example of that is there has been one really lousy study on autism and vaccines, and look how that has been remembered. That has been picked up, that has been in the, regardless of all the other studies that are out there, that has been picked up. And so oftentimes patients remember stories. I like the example of, to put smoking risk into a perspective, explain that the total number of patients, deaths from smoking in the US each day is equivalent to 2 jumbo jets crashing every day with no survivors. It kind of gives you a vivid image versus 1 in 500 or 1 in 25. And so patients tend to relate to stories better. So let's talk about risk communication. Challenges to communicating information with people is when people are scared, they often underestimate risk. And they often overestimate benefits because they honestly want to believe that something is going to help them. They're scared and they're looking for a reason to underestimate what the risk of certain things. Bioethics experts estimate that as many as 70% of patients enrolling in research believe that the research will offer them a direct benefit despite signing a consent form that says it won't. That is a huge number. George Bernard once said, the single biggest problem in communication is the illusion that it's occurred. Sometimes we don't realize that even though we've told patients and we've gone over and we've explained them, that's really not what they've read into it, and that's not what they believe. So let's start by looking at how risk is often communicated numerically. One way is frequency versus percentages. So what do we know about that? So one study looked at the side effect of a drug, and participants were asked to imagine that they had severe headaches and that a medicine could decrease headache frequencies. A possible side effect was given to participants as either a percentage, 10% of patients get a blistering rash, or they were given to it as a frequency format. 10 out of 100 patients get a blistering rash. What they found with patients with less numeracy skills perceived the medicine as less risky when the side effects were given in percent form. The choice between frequencies and percentages can often affect people's perception of the riskiness of the treatment. Absolute versus relative risk presentation. So part of the problem is when we present risk and benefits in absolute versus relative. So patients were asked to read two scenarios describing two equally efficacious medications for a hypothetical serious disease. And the benefit of one medication was stated in relative terms, and the other was in absolute terms. And patients could choose either medication alone and indicate an indifference in the choice, or choose not to answer. And so here's what it said. What if I told you a drug could reduce your chance of breast cancer by 50%? That's relative risk. That sounds really good. Or what if I told you that a drug could reduce your 5-year risk from 4% to 2%? That's absolute. You may look at it differently. The drug has the same effect in both cases. It just sounds better in the way they first described it. 57% of patients chose the medication whose benefit was in relative terms. 15% chose the medication whose benefit was in absolute terms. That's a huge difference. So the controversy about absolute versus relative is it changes the way the risk appears larger when presented using relative versus absolute. It can inappropriately lead patients to believe there's a greater chance, there's a better improvement, it's more effective than it really is. And studies have shown that even physicians were more likely to recommend a treatment if the information was presented using relative versus absolute. So what about using graphs with patients? Graphs oftentimes help us understand things, but which format do you use? So one of the studies that was done and the University of Michigan did with 2,400 participants online was they presented graphs, and I'll show you the graphs in just a second. And part of it was to look at 6 knowledge questions. 2 of them were GIST knowledge questions, and they were asked to whether or not you had a best or a worst outcome. Were you more likely to experience nausea with pill A or pill B? And 4 of them were verbatim knowledge questions. And so one group was presented bar graphs that looked like this. Another group got pie graphs. Another group got clock graphs. Another group got pictographs. And this is called a Sparkplug graph, and it's a modified pictograph. And what they found was that accuracy was greatest for pie graphs and pictographs. So the best way visually for a patient to look at this was the pie graph and the pictograph. But if you're talking about interpreting the numerical information, the accuracy was best for pictographs, and it was worse for pie graphs. Of course, the pie graphs on there didn't have the percentage, so you're going to have to guess. But neither of the graphs could predict which preference for drugs, which was interesting. So it didn't alter the behavior. It altered what the patients got, but it didn't alter what they would have chosen as the drug. So when we're visualizing health information, we want to remember to look at what display type and understanding the gist. And so the idea is to simplify. One message per graph, fewer categories, downplay the noise, white space. This is just like with health literacy and you're talking about reading. White space is always your friend. It gives patients a chance, a breather. This is an example of a horrible table that you have to try and decipher. Clarity, I thought this was a great graph that presented the way to look at this is your blood pressure. And so here is normal, and the little circle keeps getting bigger so that patients the idea behind using graphs and information like that is they need to be able to stand alone. You want patients to be able to get from just looking at it what you're trying to tell them. With text, it needs to be simple and no frills, and it needs to be clear and concise. On pie graphs, pie graphs are great for highlighting the smallest and largest pieces about if you're trying to emphasize that. One of the interesting things that you may not know is oftentimes when we look at pie graphs, we read it like a clock. And so you always want to put the largest point at 12 o'clock and go in descending order, because that's the way patients tend to look at it. That's the way we tend to look at pie graphs. And anytime you get more than 6 slices, you kind of confuse the whole thing. Visualizing health with information with bar graphs. It's easy to pick up differences. This is a great way they can see this is more, this is less. It emphasizes the rise and fall. However, when you start combining more than overlays on a graph, it gets really confusing, and patients often don't understand that. Line graphs, they actually Terry and I are on a Corey study looking at weight loss, and they chart patients' study on a line graph. And they have in the center of it your range of where you're supposed to be, and so the patients can see, and it's a great visual. Even our patients with low literacy actually like their weight charted on a line graph, because it's very clear to see when your weight is going up or it's going down. For pictographs, it's easy to show probability. Usually the best pictographs for patients with low numeracy skills are ones that just have one color. It gets a little confusing when you start. I'll show you another one. The other thing about pictographs is you can humanize the data. I like this one. It was never a dress on that image. You may have to think about that a second before you get it. But this is what I would say is a confusing pictograph for patients. You've got way too much information. They've got to figure out this box means one thing, the slash lines mean another, the colored means something else, and that's too much information. The other thing we've looked at is, does it matter when you present risk communication to patients? Does it matter if the information comes last, or is it more powerful if you tell them first? And so they did a study on tamoxifen decision aid, and they gave an internet-based decision aid to women who had a high risk of breast cancer. And half the women were asked to read the benefits first and the risk second, and the other half were asked to read the risk first and the benefits second. And so people's order does matter. People's perception and behavioral intentions were more affected by what is presented last. It's the last thing they remember when they walk out of the room. It's the last thing that you've said. It increased their worry about getting side effects. It increased their perception of how common the side effects were. And it decreased their likelihood of taking tamoxifen in the next year, just by whether or not the information on risk was presented first or last. So what are some ways to nudge people toward better understanding? One of it is describe the risk solely as such as you have a low chance of experiencing a side effect has proven to be ineffective, because our definition of low in a patient's are very different. And so they don't have a context of what low or you have a high risk. What exactly does that mean to them? Patients vary in their interpretation. Individuals with low numeracy skills should be given numbers that are accessible to them. We talked about providing absolute risk, not just relative. Keep the denominators constant, 1 in 1,000 versus 1 in 500. Keep the time frames constant. Use the same time frame when you're presenting risk and benefits. Pictographs have been shown to be really helpful. Our patients, Terry and I have done focus groups, our patients tend to like pie graphs. They tend to generally get the idea. Pie graphs are simple bar graphs that they can see the up and down movement of them. Make the difference between baseline and treatment. Pictographs are often. Also, you always have to remember what's the need to know versus the nice to know. You know, having been in medical school, you are given all information. You are just piled on information. And it's hard to back off of that and realize what it precisely is that my patient needs to know. What is the gist? What is important for them to make the decision? They don't have to know. Patients who want to know more are going to ask more questions. You know, so let them take the lead and give them the gist of the information when you're trying to explain it. Provide both the negative and the positive context. People with less numeracy skills are more influenced when it's presented in one way or the other. So a good way to help solve that is to say, for example, 60% of men who have surgery to treat prostate cancer will be impotent, and that means 40% won't, is to give them both the positive and the negative. And be careful how you interpret the meaning of important information. Oftentimes describing information in terms of goodness or badness can actually affect people's perception. One of the easiest ways to get at what your patients understand, whether it's what you said, whether it's data you presented, is teach back. It's just an old proven method. Teach back is to tell them back in your own words. What are you going to go home if you're going to tell your mother, you're going to tell your spouse, you're going to tell your significant other? Can you tell me what you're going to tell them? The other thing that I always tell when I'm teaching this is, you never want to put the patient on the spot, and the best way to do that, to not put them on the spot, is to say, I do this all day. And sometimes I either leave out information or I may have forgotten to tell you something. So if you don't mind telling me back what I need you to do and what you heard about what we talked about, and that way I can see if I missed something. That way the patient doesn't feel like they're on the spot and they're not embarrassed about it. Avoid yes/no questions. Patients with low literacy and low numeracy skills, when you ask them, do you have any questions, they always say no. 99% of the time they'll tell you no. Because, one, they don't want you to know that they don't understand something. And so they just want to get out of the office. So one of the things I'll tell you is my story of risk communication. I was pregnant at both 30 and 35. The difference in risk in being pregnant at those ages was the percentage of having a child with Down syndrome. So it went from 1 in 1,000 at 30 to 1 in 300 at 35. My test results came back, and my screening went to 1 in 75. So when I went in to see my OBGYN, he said, the first thing I said was, I was a math major. I know what 1 in 75. 1 in 75 meant nothing to me. All I could see was the 1. I would be the 1 out of the 75. And I said, how bad is this? How often do you see patients of the 35 that do this? And he said, his response was, and I love him to death, was, well, it's 1 in 75. And I thought, well, okay, that didn't help me any. And he said, Connie, if you're not going to do anything about it, I wouldn't have the amniocentesis. Now, that was from his perspective as an OBGYN. I was not going to do anything about it, but I also knew myself, and I knew that I would worry the whole pregnancy. So what I had to do was weigh the risk of having an amniocentesis, because an amniocentesis can cause a miscarriage. But for me, the benefits outweighed the risk, because at least I would know. I would know what I needed to handle. I would know how to prepare a 5-year-old that I had at home. I would know information that was important to me. And so that's the thing that you have to remember, is that in risk communication, perception is reality. What your patients perceive is their reality. When people are upset, they often distrust others that they're listening to, that they want them to be caring and empathetic and honest. And so the idea is, the studies have shown that 50% of your credibility will depend on whether you're perceived as empathetic and caring, usually in the first 9 to 30 seconds that you're in there with the patient. And that's stunning. But you have to remember that it's just like when I used to take my children to the pediatrician. When you have a screaming child and you have a child that's sick, and especially if they're an infant, you are so rattled that I probably heard a fourth to a tenth of what my pediatrician told me, because I was trying to, but the difference was I wasn't afraid to call back and ask if I had a question. A lot of our patients aren't going to call back our clinics. First of all, they don't know how to get through to our clinics, but they're not going to call back and ask. And so it's important that we look at the way we frame messages and the way we frame risk and the way that we interact with our patients. The reason I left this cartoon in here is Thursday I have flag group with my freshmen, and it is to look at their first standardized patient interviews. This is what we teach freshmen. Of course, I'm listening to your expression of spiritual suffering. Don't you see me making eye contact, striking an open posture, leaning towards you, and nodding emphatically? The only thing that's missing is I'm sitting on your same level. You know, I mean, that's what I will be looking for on Thursday when they're talking about it. You know, do they make eye contact? Are they on the same level as the patient? Did they introduce themselves? Well, part of the other thing is teaching our medical students and getting you to understand that how you present risk and benefits and how you talk about risk communication makes an impact on your patient. It makes an impact on the way they decide to do things, whether or not they're going to enroll in a procedure, what they believe in. They trust you. That's one thing the literature shows. That's one thing all the focus groups that Terry and I have done is their provider is their first line of defense. They trust what you say. And so oftentimes with patients, the key thing to helping understand them is to paraphrase what they're telling you back. It's to take the second to listen and go, what are you saying back to me? So, and repeat what they're saying so you can make sure that y'all are both on the same page lane. You're on the same page. It's always important to remember that not to make assumptions about understanding, to make the implicit explicit, to ask open-ended questions, to tailor the information for the patient and what you think they can handle, to reinforce important messages, and to confirm understanding. So one of the things I want you to remember is that seemingly minor differences in risk presentation can change risk benefits perceptions and knowledge and decision-making for patients. And that we need to make conscious decisions about how the discussion of risk and benefits of treatment and screening is made to patients. And y'all are going to get out early today. So yeah, that's it. Do any of y'all have any questions? Okay.